welcome to webinar series. So myself Shanti, and today's session for discussion is all about bone marrow transplant, a life-saving treatment for blood cancers and blood disorders with growing success rates. We all thank to onco experts skill for the same. Having said this, let's welcome Dr. Faraz MG, who is our consultant hematologist and bone marrow transplant physician from Yashoda Hospitals, Malakpet unit. I welcome you, sir.
Thank you so much, Shanti. Hi, everyone, all the speakers.
Thank you. And we all are privileged to have you with us today.
Thank you so much. Thank you. Thank you for this opportunity.
And I may now request all the speakers to introduce themselves. Yes, over to you, Aruna.
Hello, ma'am. Good afternoon. I am Aruna Kumari, working as a nurse manager in Renova Hospital, Banjara Hills. I am very happy to participate in the program, ma'am. Thank you.
Thank you. Yes. Yes, Nupur.
Good afternoon, everyone. My name is Nupur. I'm the nurse manager in the medical wing, 4th A. And thank you so much for given an opportunity for the part of the webinar. Thank you.
Yes, Sandhya.
Yeah, good afternoon, everyone. First of all, thank you for giving me this opportunity. My name is Sandhya. I'm from Fortis Hospitals, Bannerghatta Road, Bangalore.
Yes.
I'm working in oncology department as a senior nurse.
Thank you. Thanks for accepting this invite to all these speakers. Yes. Going forward, we wish to understand from Faraz sir now, yes, as we know the growing prevalence of cancer in national and globally across. So we'd like to understand what is the bone marrow transplant and how it is a life-saving procedure. As we know, cancer mortality is significantly rising. Yes, over to you, sir.
Yeah, thank you so much. So first we need to understand what is a bone marrow actually is. So bone marrow is a spongy tissue, soft spongy tissue in our inside the bone of a healthy human being. So what's the function of bone marrow is it produces RBCs, WBCs and platelets. So in few conditions, the patient bone marrow gets damaged, like in cancer, post-chemotherapy, radiotherapy, or some in genetic disorders. So the patient is unable to produce RBCs, WBCs and platelets. So in bone marrow transplants, basically it's a medical procedure in which a healthy stem cells, bone marrow stem cells, are infused in the patient so that he is able to produce this RBC, WBC, and platelets.
Yes. Yes. So let us learn together again what we have in this session today. Yes, over to you, Nupur.
Thank you, sir, for the beautiful session. First, sir, I have this has a little concern about that. Who are the patients needs a bone marrow transplant? Like we have seen so many cancer patients, right, with the leukemia, with the sickle cell. Who the patients are the required for this transplant?
Absolutely. So the bone marrow, the patient who should undergo bone marrow transplant, they fall in the category of cancerous and non-cancerous condition. Cancerous condition like leukemia, AML, ALL, lymphoma, multiple myeloma, and non-cancerous condition like severe aplastic anemia, sickle cell anemia, and thalassemias. And also there are few conditions like immune disorders, some genetic immune disorders, in which the patient should undergo bone marrow transplant.
And when you spoke about thalassemia and a bit of immune disorder, so these are all inherited immune deficiencies.
Yes, absolutely. Absolutely. Sickle cell is a congenital genetic disorder in which there is defective hemoglobin. The patient is unable to produce proper normal hemoglobin. So he or she is anemic throughout his or her lifetime. So the bone marrow is absolutely indicated in that condition.
Yes, Aruna. Yeah. Aruna, are you there?
Yes, actually, I have seen so many cases in autologous and allogenic, ma'am. I have one doubt about what is the most challenges part of handling the patients across different age groups.
The most challenging part in adults, especially, is the age, comorbidities, and fitness, actually. So pediatric patient, they can tolerate the high dose chemotherapy and the procedure well. comparatively the adults, especially the older adults above 50, 60, they are unable to tolerate this high dose chemotherapy. So we as a transplant team, we do a pre-transplant evaluation in which we check for all the organ functions like heart function, liver function, kidney function, and all those things, lung function also. So if they are fit enough to tolerate this high dose chemotherapy, then only we proceed with the transplants. So these are the particular challenges we face. Especially one more challenge is finance. Obviously, finance is the main criteria. Even if every box is ticked, if the patient is financially not affordable, then we cannot proceed. Unfortunately, we cannot proceed with the transplant, even if all the indications are there. Plus donor donor has to be there, especially HLA match sibling, 10 by 10 match sibling donor, it should be there. If 10 by 10 match is not there, we go for haplo or a mud transplant. Yeah.
Yeah. Great going. And yes, let us also, yes, Sandhya, do you have your insight to be, clarified?
Sir has told the criteria and age groups and all. I would like to know about, is it necessary to do a bone marrow biopsy before BMT, sir?
Absolutely, yes. Bone marrow biopsy is definitely indicated before the transplant to know the disease status, because there are studies in which we have seen that if the disease is not in remission, if the disease is not properly managed, and we go ahead with the transplant, the transplant outcome is not that optimum, that good.
Yes.
So before going for the transplant, we should make sure with the bone marrow biopsy and few other tests that the patient is in remission. Then only we take the patient to transplant.
And it can also happen with the, client who has already undergone for the, bone marrow transplant, and maybe there is a recurrence or, relapse of the state, and then again the patient gets admitted, and then that's how we again evaluate.
Yes, definitely. Because if there is a recurrence of the disease, then we cannot go with the transplant straight away. We need to bring the disease into remission with some chemotherapy cycles, and then only we can go ahead with the transplant.
Sir, as you told regarding the ALL, that if the patients are not like good enough financial, so what can be the other way so they can go ahead for this if they need it is very necessary for that? Options.
Do we manage with only chemo, radio, or immunotherapy? How do we manage? Or I know it is a very challengeable factor for you also, because
yes. No, we definitely give chemotherapy or radiotherapy depending upon the status of the disease and the patient. We if the transplant is not possible, then we go ahead with the chemotherapy and try to bring the disease into remission. Definitely.
So yes, and regarding this, I think this slide is a very important slide, because whenever we go for rounds, we see kidney transplant and organ transplant, and BMT nurses, they keep doing a lot of pre-evaluation criteria of sending samples, talking to the coordinators, liaising with you, etc. So what is HLA, human leukocyte antigen, means in simple terms? I'm very sure this is a very core fundamental blood criteria which should be matching with the donor and recipient. Sir, over to you for your simple explanation of this.
Absolutely. The transplant outcome relies on HLA matching. If the HLA matching is not there, the patient will have a lot of complications, like GVHD is the main complication that leads to morbidity and mortality in transplant settings. So HLA is basically it's a set of genes. It's basically sets of genes which make proteins or antigens which are present on all our cells of the body.
Yes.
So there are class 1 and class 2 antigens. So these antigens help immune system determine what is self and what is non-self. So they present these foreign antigens or bacteria, whatever, to these immune cells, and they decide whether to reject them or accept them. So a 100% matching, HLA matching between the donor and recipient is the primary criteria to undergo bone marrow transplant and to get the optimum result from the transplant.
What is the most criteria regarding of this? How we'll find this is a good match of this HLA, sir?
So we do HLA matching. We send sample, patient sample and the donor sample to a lab. And usually results comes in 2 or 3 weeks. They match at the allele levels, HLA, B and C, and DP, DQ and DR. They match at these allele levels. If there is a 10 by 10 match, then we say that's, yeah, it's a match sibling donor, then we go ahead with the transplant.
Okay, thank you, sir.
That's very interesting. And going forward, like, yes, like maybe a nurse, her perspective maybe is, she may think that patient is taken to operation theater for bone marrow transplantation. Like the myth and fiction about the robotic surgery, that robotic arms, they operate on the patients. It is not the robotic arms. It is just a facilitating tool. But console is operated by the expertise who is none other surgeon and doctor. So correlatively, what is bone marrow harvesting and transplant? Like harvesting means the harvest from the recipient or donor body and transplant into the recipient's body. Sir, yeah, your insight is the same.
Well, bone marrow harvesting is a procedure in allo and auto settings. In auto setting, basically, it's harvesting is a procedure in which blood stem cells are collected from the patient itself. The patient itself is a donor.
Yes.
So we perform autologous transplant in myeloma and lymphomas usually, and in some solid cancers. So what happens is that first we mobilize the patient. First, the patient has to be in remission. The disease has to be controlled. Then we mobilize the patient. Mobilizing the patient means we give GCSF injection, whatever you call Grafil, Nukind, whatever. So for 5 days, we give GCSF. On fifth day, we take the patient with the central line to the apheresis machine. We collect the stem cells.
Yes.
That is called harvesting.
Yes.
Collecting the stem cells. It's not a surgical procedure, it's a medical procedure, totally. And it is absolutely devoid of any complication. There are no complication at all, apart from occasional body pains, bony pains with the patient. That is manageable. And in case of allogenic, where there is a donor, separate donor, we again give GCSF and we mobilize the donor for 5 days. On fifth day, we collect the stem cells. That's called harvesting. And we infuse that stem cells to the patient. So infusing stem cell to the patient doesn't mean it's a surgery. It's like any other blood transfusion.
Yes.
We give through central line. It's totally devoid of any surgical procedure. It's a medical procedure.
So soon after the harvesting, the marrows are transplanted to the recipient body? Or is there any ideal time frame?
In case of allogenic, 24 to 48 hours, within 24 to 48 hours, we infuse the stem cells. Yes. And in case of auto, there is fresh infusion or cryopreserve infusion. In case of fresh, we transfuse, same thing, we transfuse within 24 to 48 hours. And in cryopreservation, we cryopreserve the stem cells. What we have collected, we cryopreserve in a chemical called DMSO, dimethyl sulfoxide. Yes. And we freeze the stem cell in liquid nitrogen, and we can keep that stem cell for at least 10 years. And whenever we need, we can thaw the stem cell and we can reinfuse that into the patient.
I think that's a very interesting insight which we have come to know today. Yes, and yes, going forward, I think this is a basic slide and the learning which every nurse should know, not only just working and taking care of the patient, at least she should also understand, what are the types of BMT.
Yeah.
Over to you, Sandhya.
Already, sir has explained there is two types of bone marrow transplant. So we would like to know in detail about that, sir. What is autogenous and what is allogenous?
Autologous.
Yes, sir.
Sure.
And then how the patients react to that.
Sure.
What are all the condition of the patient? Like we can go for that.
So autologous transplant, the main indication is myeloma, multiple myeloma and lymphomas, Hodgkin and non-Hodgkin lymphomas. So multiple myeloma, we do upfront transplant after 4 cycles of induction chemotherapy, and sometimes in relapse or refractory settings, we do multiple autologous transplant. In lymphoma, we can wait and watch the patient after 6 cycles of chemotherapy. If the patient is doing fine, we don't transplant. But if he comes after remission, he relapses, then we go for transplant, autologous transplant. In autologous transplant, the patient himself is a donor. There is no separate donor. Patient himself is a donor. It's also called stem cell rescue. This procedure is also called stem cell rescue. So we are rescuing the patient stem cell and reinfusing those stem cells to the patient. So there are the complication in autologous transplant is minimal. There is very less complication compared to autologous. Autologous is more toxic, more risky. In autologous transplant, there will be no chance of rejection because there is no HLA matching. There is no need of HLA matching. So rejection in GVHD rate is very low, negligible, 0%. And patient tolerates the chemotherapy and stem cell therapy quite well in autologous. Whereas in allogenic transplant is a different thing altogether. Allogenic transplant is highly risky and a life-saving procedure, definitely. We do allogenic transplant in leukemias, severe aplastic anemia, sickle cell anemia, thalassemias. So these are the conditions we go for allogenic transplant. So first prerequisite is a donor, HLA matched donor, matched sibling donor we prefer, number one. Second will be MUD, matched unrelated donor. Third will be haplo, and fourth will be cord blood. So after allogenic transplant, there is a very high chance of GVHD because along with the stem cell, we are giving donor T cells also. So these T lymphocytes are quite aggressive. They can react with the healthy tissues of the recipient. So what we call, when they react, we call GVHD. So this GVHD we need to watch out for, plus infections.
Sir, how to identify early GVHD, sir?
So there are two types of GVHD, acute GVHD, chronic GVHD. Acute GVHD usually presents within 3 months and chronic GVHD after 3 months. So acute GVHD, most likely they target the skin, liver, and GIT. So the red flags are rashes, especially in palms and soles, persistent vomiting, diarrhea, and pain abdomen and jaundice. So these symptoms we need to watch out for in acute GVHD. And chronic GVHD can affect any organ system, eyes, mouth, lungs, anything.
Yes, sir.
Yeah, very
in this criteria, any very specific for the samples we need to look up, like a liver function test or any lipid profile, any kind of we need to look up for that?
Yeah, GVHD, we definitely need to monitor LFTs. In particular, GVHD, we definitely need to monitor for LFTs. And if there is a diarrhea, persistent diarrhea, we need to go for colonoscopy also. Sometimes colonoscopy with biopsy. That's the gold standard. Yeah.
So I'm sure
so it is very important for the SGOT and SGPT, sir?
Yes, SGOT, SGPT is important along with the bilirubin levels, direct bilirubin levels, especially, and the alkaline phosphatase levels. So these are the parameters we need to watch out for.
Yeah. So interesting about this, this subject. And yes, sir, you were continuing with your answer.
Oh, I'm done.
Yeah. So yeah, I think recently we have I keep seeing this our website for haploidentical transplant, and is this considered and one of the advancement or a new method, sir? As you were talking about allo and auto and haplo. So yeah, your insight on the same, because yeah, the logistics says a 50% match with a 100% chance. Yes.
Yeah, correct. So haploidentical BMT is considered an advancement, not a new method. Basically, it's an advancement in allo BMT, in allogenic BMT. So basically, what happened, in the past, when there was no 100% match, 10 by 10 match donors, no unrelated donors were there. So they used to do haploidentical transplant. Haploidentical means 50% match, 5 by 10 match. So haploidentical donors are always there in your family. Like parents can be a haploidentical donor, children can be a haploidentical donor, siblings can also be a haploidentical donor. So what they saw in the past, that when they used to do haploidentical transplant, there was a very high rate of GVHD infection and graft rejection. So in 10 to 15 years back, they came up with a very breakthrough drug called PTCy, post-transplant cyclophosphamide. So in day +3 +4, they infused the cyclophosphamide, post-transplant cyclophosphamide, and they saw that the GVHD rate and graft rejection rate was very low comparatively to the earlier studies. So haploidentical became famous from that from then on.
Yes. And I think, Nupur, you wish to ask, regarding this cord sample, as we were discussing in the morning, because nowadays we see a primary mother, they have been asked to preserve their cord blood, sample and all this. So
Yes, sir.
yes. So
Like
Will you
to
please a little
about that.
elaborate, sir, for regarding this?
like, how about the role of cord blood stem cell
Yeah.
Cancer treatment.
cancer?
Yeah, cord blood, we don't commonly do cord blood.
Preservation.
But in few situations, we can go for cord blood situations like if there is no donor at all. So there is no match sibling donor, no haploidentical donors, no mud donors. So in last resort, we can go for cord blood transplant. Cord blood transplant doesn't need any strict HLA matching, first of all. So there is no strict law, hard and fast rule that we have to be 100% matching should be there, or within a family should be there. Unrelated cord blood will do good. So especially in pediatrics, we can definitely try cord blood transplant. In the pediatric, the result is very good because the cord blood has a stem cell dose is very low. So pediatric, the weight is less. So the stem cell requirement is also very less. Dose is very less. So cord blood has done very good in pediatric patient. In adult patient also, if we can double the dose, double cord blood transplant we say. So we can do cord blood transplant in adult also in few situations.
And I think many more researchers and methodologies are waited for this. Say yes.
Yeah.
And yes, Sandhya, do you have your insight?
I would like to know about the remission and relapse, sir. As we were keep on talking about the remission and relapse.
Because one thing is
What
like
does it mean, actually?
yeah, sometimes we see the oncologists, they write AML in relapse stage or remission. So, and we ask the nurses, so what is all about? She might tell, Kina, ALL is this, but then she did not understand what is relapse and remission. Please provide your insight on this.
Definitely, sure. Remission is a very broad term. Remission we oncologists use when the disease is proper under control. So there is no signs, no symptoms, and we do a bone marrow. Bone marrow is very important before calling any cancer in remission, especially blood cancer. We go for biopsy, we go for bone marrow examination, and if there is no evidence of disease in the bone marrow or blood, we say, and there is no signs and symptoms of disease, we say the patient is in remission. Completely, the disease is not there. And plus, along with, have you come, I want to ask all the audience also, have you come across a word called MRD? MRD. Yeah.
Okay.
Measurable residual disease.
No.
So this concept is new. So to call it a proper remission, we also do MRD levels also. MRD is like beyond the microscopy, what the pathologist will see. So MRD is a molecular definition of remission. If MRD is negative, and then we call the disease in remission. Relapse is something else, opposite. Relapse is when the disease is in remission. If it's come back, then it's called relapse.
Yes. And please try to tell again this abbreviation of MRD.
Measurable residual disease.
Yeah. Thank you.
If a patient we have done the bone marrow transplant and patient is relapsed, is it possible again we can transplant or go for BMT?
Very good question. Yes, definitely. If the patient is fit enough to handle the second procedure of the transplant, able to handle the risk and all those things, definitely we can go for second transplant, but with a different donor.
Okay.
So, yeah, this is a very interesting subject, and I think this session is going to be very time-bound. And we have come to the end of the session as we wish to understand. I know I tried to mention little few of the post-discharge what
Post-transplant.
clients should follow. Any other typical cautions which you would like to give us as a learning take-home message, sir? Apart from taking medications, monitor for GVHD and diet hygiene, all that. When the BMT or the healthy, let's say 40 years of age, they can resume their work and they can, mingle in the little society, like because they always isolate themselves. Yes.
Definitely, the post BMT care is absolutely vital.
Yes.
So it's more important than the procedure itself. So because the immunity is very weak post BMT and the RBCs, WBC platelets are still catching up with the normal levels. So the patient is very prone to infection, life-threatening infections. So infection prevention strategies are very important. Frequent hand hygiene, uh, avoiding contact with the sick people, avoiding going out in the crowded place, wearing mask all the time, eating cooked fresh food, avoiding raw fruits and vegetables, which we all give suggestion to all the patients.
Yes.
Medication is very important, especially GVHD prophylaxis medication like cyclosporin, tacrolimus, MMF. These medications should be taken under proper guidance, and the dose should not be omitted. The dose should never be omitted or reduced by patient himself. Always consult your physician. And yes, of course, the GVHD signs and symptoms, the red flags like persistent vomiting, diarrhea, rashes, jaundice, this should be looked into it. And if any fever post BMT, the patient should definitely get the medical help, contact the medical staff.
Yes.
Any fever.
Yes. So yes, this is our last slide, and I request all the speakers, do you have any other concern to be just cleared upon? Otherwise, we are just trying to end the session. Yes, Nupur, yes, Aruna, and yes, Sandhya. Okay. So yes, Aruna, do you want to take the slide?
And cyclosporin, like prophylaxis, till how many years are we have to continue, sir?
At least 3 months. 3 months minimum. We should continue 3 to 6 months. We give cyclosporin depending on the condition and status of the patient clinically.
Okay.
Yeah.
So as you told, like there will be a very strict diet that they have to take care of. What about the output? We need to be monitored for the output for the patient.
Output in the sense the urine and stool output.
Yes, yes.
If the patient is stable, there is no need to monitor the output. But yes, in case of diarrhea, definitely, because there are categories of GVHDs, stage 1 to stage 4. So to categorize how severe the GVHD is, especially the gut GVHD, so we need to measure the output in that scenario, not routinely.
Yes.
Okay, not in a routine.
Sir,
manner. But
what
they
is
continue
the
with all the medicines, right, sir? So there is any effect, side effects for that medicines?
Yes, definitely. So I talked about cyclosporin. Though the cyclosporin levels for the first 3 months, for the third 3 to 6 months, whenever the patient is on cyclosporin, we monitor the drug level of the cyclosporin every weekly. So that is very important. So that if the drug levels are high, the toxicity will be there. Toxicity in the sense, according to the cyclosporin, like renal failure, the patient can go into renal failure, hypertension. So we need to watch out for those things also. Definitely.
Thank you, sir.
So yes, we are just trying to end the session, and I request all the viewers to share this, link so that the awareness can be given in all the sectors. And I urge all the viewers to just refer www.yashodahospitals.com for more academics and health update and patient testimonials. As I was just watching your, this reels, which is very short on multiple myeloma and lymphoma. And I request all the viewers that you need not to just, think that this is not going to be Telugu. Sir is giving in, Hindi as well. So I request sab dekhe and at least aware ho jayegi what all, things or situations we can prevent. Yes. Thank you, sir, for your very valuable,
Welcome. Welcome.
participation. And I thank all the beloved speakers for your valuable
Thank you, sir. Thank you, ma'am.
participation. Yes.
Welcome.
Thank you, sir, for valuable
Thank
input.
you, sir.
Thank you.
Thank you. And we end the session.
Okay.
Thank you so much.
Thank you, sir.